Dr. Reut Halperin, an endocrinologist from Sheba Medical Center in Israel. I would like to thank you for the opportunity of presenting our research on unique characteristics of von Hippel-Lindau disease associated pancreatic neuroendocrine tumors by various diagnostic criteria. We all know the clinical manifestations of VHL: hemangioblastomas of the retina and central nervous system, endolymphatic stack tumors, and visceral involvement, including renal cell carcinomas, pancreatic neuroendocrine tumors, and pheochromocytomas. We have two diagnostic criteria for VHL, the international and Danish criteria. A diagnosis according to the international criteria can be carried if a patient has multiple hemangioblastomas or one hemangioblastoma and any one visceral lesion. In addition, a diagnosis can be made if a patient has a positive family history of VHL and any one clinical manifestation. Diagnosis according to the Danish criteria is a bit more liberal and allows diagnosis if a patient has any two VHL-related manifestations, or if a patient has a pathogenic variant in the VHL gene and any one clinical manifestation, or if a patient has at least one first-degree relative with VHL and any one clinical manifestation. When looking at VHL-related pancreatic neuroendocrine tumors, or for short, VPNET, we find that the prevalence of VPNET ranges between 8 to 17%. VPNET differs from sporadic pancreatic NET, or for short, SPNET, in that they are diagnosed at a relatively younger age, are more often multifocal, rarely functional, and have a relatively lower grade and low risk of metastasis compared to sporadic pancreatic NET. Stemming from this, management recommendations differ between VPNET and SPNET. Our research question was, do VHL patients diagnosed according to the international or Danish criteria form two distinct populations? Our objective was to compare the characteristics of VPNET diagnosed according to the international or Danish criteria. Our cohort included patients diagnosed with pancreatic NET or VHL based on the Danish criteria, which in fact encompasses the international criteria, and followed at Sheba Medical Center between the years 1995 and 2021. We gathered information regarding the demographics and tumor characteristics of the patients, clinical features and family history relevant to VHL, and VHL genotyping. Patients were then subgrouped to SPNET or to VPNET based on the international or Danish criteria. For the results section, our study population included 65 patients with SPNET and 17 with VPNET, 9 diagnosed according to the international criteria and 8 according to the Danish criteria. We had a total of 29 VHL patients, 19 diagnosed according to the international criteria and 10 according to the Danish criteria. When comparing VPNET to SPNET, we found that age of diagnosis was younger for VHL, averaging 50, compared to the sporadic group, averaging 62 years of age. We did not find any difference between the grade or the stage of sporadic and VHL-related pancreatic NET. However, the location of the pancreatic NET within the pancreas differed between the two groups, as in the sporadic group, the location within the body and tail of the pancreas was more often compared to the VHL group. In addition, patients in the sporadic group were more often operated on or receiving systemic therapy compared to the VHL group. When comparing VHL diagnosis based on the international or Danish criteria, we found that patients diagnosed with VHL based on the international criteria were younger at diagnosis, as can be seen here. Patients diagnosed according to the international criteria in blue, and patients diagnosed according to the Danish criteria in orange. Age of diagnosis was younger for the international group and compared to the Danish group. This was also true for other clinical manifestations of VHL, including pancreatic NET, renal cell carcinoma, and pheochromocytomas, In all three, age of diagnosis was younger in the international group compared to the Danish group. If we look further in the pancreatic net diagnosis age, we find that for the international group, on average diagnosis was made by age 40, and in the Danish group, diagnosis was made on average by age 62, which was identical to that seen in the sporadic group. Regarding family history and genotyping, we found that for the entire cohort, 10 out of the 19 patients in the international group had a family history of VHL, compared to none out of the 10 patients in the Danish group. When looking at patients with both VHL diagnosis and pancreatic net, 6 out of the 9 patients in the international group had a family history of VHL, compared to none in the Danish group. For the patients that underwent genetic testing, we found that 15 out of the 16 patients tested in the international group had a pathogenic variant in the VHL gene, compared to none out of the 3 patients tested in the Danish group. When looking at patients with both VHL diagnosis and pancreatic net diagnosis, we found that 8 out of the 9 patients tested in the international group had a pathogenic variant in the VHL gene, compared to none in the Danish group. To summarize, patients diagnosed with VHL based on the international criteria and Danish criteria have distinct characteristics. When using the international criteria, patients are younger at diagnosis with VHL and its manifestations. Danish-only criteria may include patients with sporadic disease, as RCC is relatively common and sporadic pancreatic net incidence is rising in the general population. We therefore suggest that clinical VHL diagnosis should be supported by genetic testing, especially when diagnosis is based on visceral manifestations alone. I would like to thank my colleagues at the entire Center and at the Center of Endocrinology, Diabetes and Metabolism, especially Professor Amiti Rosh. And thank you for listening. Any questions?
Questions are open at this point. Dr. Amit Tirosh will be answering the questions. Again, please feel free to raise your hand or send the question via the chat. I don't see any questions, so I'll just ask you one question. Why do you think those differences exist?
Well, thank you for the question, Karen. I think that the diagnostic capabilities of CT and MRI are improving every day, and I think that the sensitivity is increasing. So we identify renal cell carcinoma very early and in very small lesions, and the same is true for pancreatic net. So it's not uncommon, and I'm sure you are very experienced in that, to find small lesions in the kidney and small pancreatic net in the tail of the pancreas. We don't need to do anything about that. But based on the Danish criteria, you can set the diagnosis of VHL in these cases. And we all know that clinically, it's probably not a real, so to say, VHL. And we showed here that we didn't see any genotype, any aberration in the VHL gene in most of these cases.
Mm-hmm. Dr. Kim, you have a question as well.
So Amit, it's very interesting that these different criteria exist, and I often wonder if we should just harmonize all of them. But then, as you say, different criteria result in different types of buckets in the end. What's your approach to, like, let's just say patients are coming to you for pancreatic neuroendocrine tumor. Do you genetically test them all for VHL, or do you use a panel, or do you use age threshold? This is mainly a genetic testing question. Like, we in Ontario haven't really touched GI and neuroendocrine tumors in the abdomen because it's fairly complicated. I know anecdotally, Karen and I have, like, we're lucky we can do like a big panel on them, but what do you guys do?
So this is an excellent question. So we are lucky to have high availability of genetic testing, and we can do single sequencing very easily for VHL, etc. So we have a very low threshold for doing this testing. So we don't rely heavily on the clinical criteria. And we can do it as part of a clinical study that we do in our lab. So we don't have any difficulty doing the genetic testing. And in a perfect world, I'm sure that all of us will do the same. I mean, we can do the genetic testing for VHL, which is very high sensitive, except for if you are deletion, you need more than a single sequencing. And but the main point of this study is for the cases in which you are not able, you don't have reimbursement for the genetic testing. In this case, I think, or what Reut suggests, is that we'll use more stringent criteria and maybe more stringent age threshold, such as, if you have pancreatic net at the age of younger than 35, 30, 40, if you see non-visceral manifestation, then you can suspect VHL and move forward. But based on RCC and pancreatic net at the age of 50, 55, 60, it might be very problematic to define VHL.
Thanks, Amit. Cool.
Thank you.
Dr. Van Leeuwen, please go ahead.
Hello, Dr.
Yes.
Amit, thank you for this interesting talk. So I have a question. In patients who have small lesions in the kidney and a pancreatic neuroendocrine tumor, which is confirmed, but no VHL mutation, germline, would you suggest to do surveillance according to VHL or no, or none?
So the very frank answer will be, I don't know. I really don't know. I mean, if I have a young patient, about a 50-year-old with both pancreatic net and RCC, I don't have any confidence to say that he or she doesn't have a VHL, and I will follow them as they were, considering as they have a VHL. But I have patients that have pancreatic net and RCC in the age of 60 or 65 that I will follow them less stringently that comparing to patients with 2 hemangioblastoma at the age of 13. You see what I mean?
Yeah,
So,
I agree. That's what we also would do. We'll just follow up, but maybe the interval for screening, you can lengthen it a bit more.
yeah, exactly.
There's,
Thank you.
Thanks.
Thank you. There's an additional question from Dr. Patricia Daya. Do you think VHL patients with PNET alone or PNET and pheochromocytoma might comprise specific subgroups of VHL disease?
So first, congratulations for your fascinating talk, and thank you for the question. And again, I cannot say that I know for sure or I'm confident about it, but I believe that they do make a different or distinct group within the patient with VHL. We know, of course, for many years that pheochromocytoma are related for a specific type of variant. The patient without missense mutation will have very low risk to develop pheochromocytoma. And we also know that missense variants in the VHL gene are associated with higher risk of pancreatic net. So I think that we can say that patients with pheochromocytoma and pancreatic net will probably have some subtype of VHL that differs from the patients that have mainly renal cell carcinoma and hemangioblastoma. And clinically, we do see these distinct groups.
Thank you, Dr. Tirosh.